Today, I want to talk to you about sepsis. Let me start with a definition. Sepsis is a clinical syndrome that has physiologic and biochemical abnormalities caused by inappropriate response to infection. All patients with infection or bacteremia are at risk of developing sepsis. Sepsis is the leading cause of death in the non-coronary ICU. More than 18 million cases occur worldwide each year, and the mortality rate is approximately 30%. This increase can be attributed to more invasive procedures and a larger number of elderly and persons who are at high risk. It is important, therefore, to have early recognition, diagnosis, and the treatment of sepsis in order to reduce this high mortality rate. Here is the schematic. So let's take a look at this sequence. First, we will have infection and bacteremia. This can progress to sepsis. Untreated, sepsis can progress to severe sepsis. Severe sepsis can progress to septic shock, and a septic shock can progress to multiple organ dysfunction syndrome and ultimate death. Infection requires an organism to invade the body and penetrates the defense mechanism. If this infection is not recognized and treated early, it can progress into the blood. Once the organism enters the blood, it's called bacteremia. It should be noted that not all infections result in sepsis. The term is applied to patients who present with an infection and a combination of the following. This would include hyperthermia, hypothermia, tachycardia, tachypnea, leukocytosis, and leukopenia. Severe sepsis occurs when the patients come in with an organ dysfunction, hypertension, oliguria, altered mental status, and the labs show lactic acidosis. These patients should be treated aggressively with fluid. Septic shock means that the patients have severe sepsis with hypotension and are being treated with fluid but are not responding to the treatment. The result of septic shock is multiple organ dysfunction. Most, if not all, the organs of the body begin to shut down. The final result is death. So far, I have spoken about, number one, infection and bacteremia and the consequences of not treating it early. Number two, we have spoken about sepsis. Now, untreated bacteremia will progress to sepsis, which, as we said before, is the result of poorly treated or untreated infection, and of course, bacteria in the blood. Severe sepsis is a result of sepsis that includes organ failure, hypotension, oliguria, and altered mental status. If severe sepsis is unresponsive to treatment, it progresses to septic shock. And septic shock, as I said before, is a result of severe sepsis not responding to appropriate treatment, particularly fluid resuscitation. Septic shock, on the other hand, will progress to multiple organ dysfunction and ultimate death. I want to turn my attention to lactic acid. Number 1, hyperlactatemia has been shown to have a great prognostic value. However, one has to keep in mind that there can be decreased clearance by the liver. Number 2, it is elevated in sepsis. Number 3, lactic levels are usually elevated in anaerobic respiration, hypoperfusion, or defective oxygen extraction. Number 4, elevated serum lactate is associated with increased mortality, but if after aggressive hydration the lactate level decreases, then the outcome will be better. And number 5, it is important, therefore, to order lactate on all patients who present with signs and symptoms of an infection. Due to the seriousness of sepsis, screening tools have been developed to identify early sepsis. Let's talk about those tools. First, the question should be asked, does the patient's history suggest infection? If the answer is yes, then the next step is to identify if any two of the following are present, such as number 1, hyperthermia, which is temperature greater than 38 degrees Celsius or 101 degrees Fahrenheit. Number 2, hypothermia, which is a temperature less than 36 degrees Celsius or 96.8 degrees Fahrenheit. Number 3, tachycardia, which is a heart rate greater than 90 beats per minute. Number 4, tachypnea, which is a respiratory rate greater than 20 breaths per minute. Number 5, altered mental status. Number 6, leukocytosis, which is the WBC level greater than 12,000, or leukopenia, which is the WBC level less than 4,000. And finally, glucose greater than 120 milligrams per DL in the absence of diabetes. So, if the patient's history suggests infection, and there are two of the above features present, then the clinician should not only be highly suspicious of an infection, but also of the presence of sepsis. The next step is to order the appropriate labs. The clinician should order, number 1, lactic acid and blood cultures, number 2, CBC with differentials, number 3, BMP, number 4, LFTs and lipase, number 5, C-reactive protein, number 6, a UA, number 7, ABG, and number 8, a chest X-ray. So, what do we have so far? Let's review. So we have, number 1, a patient whose history is suspicious of infection. If that patient meets the criteria, the screening criteria, and have two components in the screening criteria, then that patient now becomes highly suspicious of not only an infection, but of sepsis. In addition, if the lactate and WBC are elevated, then it is no longer a suspicion, but it is clinically proven that the patient is septic, that sepsis is present. Once we prove that sepsis is present, it becomes the clinician's responsibility to prevent that patient from progressing to severe sepsis. So the next step is to make sure the patient does not progress to severe sepsis. The questions that are to be asked are these. Are there any of the following present? Number 1, is the MAP less than 65? Or the systolic blood pressure less than 90? Number 2, is the systolic blood pressure greater than 40 millimeter of mercury from baseline? Number 3, is there bilateral infiltrate? Number 4, is the creatinine greater than 2 milligrams per DL? Number 5, is the urine output less than 0.5 ml per kg per hour for the last 2 hours? Number 6, is the bilirubin greater than 2 milligrams per DL? Number 7, are the platelets less than 100,000? Number 8, is there coagulopathy? Is the iron R greater than 1.5 or the PTT greater than 60? And number 9, is the lactate greater than 4 millimoles per liter? If the patient has any of the above features, then the patient can be described as having severe sepsis. Time is tissue. Don't forget, time is tissue. Now that the diagnosis of severe sepsis has been made, what is the next step? Well, there are a few steps that needs to be taken in almost simultaneous fashion, but for the purpose of breaking it down, I will put them in numerical order. But remember, these functions are occurring almost at the same time. So number 1, there should be an active sepsis alert. Activate the sepsis alert. Number 2, there should be fluid bolus of crystalloid, and it should be at a rate of 30 ml per kg over 1 hour. Number 3, blood cultures should be done prior to antibiotics administration. Number 4, oxygen and cardiac monitor should be implemented. Number 5, a chest x-ray should be done. Number 6, a central line should be inserted. And number 7, the patient should be admitted to the ICU. Reassessment of the severe septic patient should be done every 2 hours. So after the first 2 hours, the goal is to clear the lactate by 10% every 2 hours until the lactate level is normal. So these patients need reassessment every 2 hours. The fluid bolus may need to be repeated. And if the person has a CVP, the CVP line, if they have a CVP line, the CVP should be greater than 14 for intubated patients and greater than 10 for non-intubated patients. And if needs be, the blood work should be repeated. In closing, these are the things I want you to remember. Number 1, patients with a history and physical that suggest an infection should be suspected of sepsis if they have 2 of the following. That is, temperature greater than 100.9, heart rate greater than 90, respiratory rate greater than 20, and altered mental status. Number 2, patients are recognized to have severe sepsis when 2 of the above criteria plus organ dysfunction are present. Number 3, septic shock is a result of severe sepsis not responding to treatment. Number 4, serum lactate is a good prognostic indicator. Number 5, aggressive fluid resuscitation is essential in the first hour. Number 6, culture should always be done before administering antibiotics. Number 7, patients should be reassessed every 2 hours. And number 8, patients should be admitted to the ICU. There is a thin line, and this thin line is the fact that not all infections become bacteremia. But if there is bacteremia, then there is sepsis. Well, this brings us to this short review of sepsis. I wish you well. Don't forget to like, subscribe, and share. Good night.